Welcome to Dental XP. Today, Dr. Maurice Salama, I'm going to take you through the restoration implant placement in the area of the maxillary left first bicuspid, utilizing crestal incisions and an osteotome technique for sinus lifting. We're going to use sulcular incisions on either side of the edentulous span to expose the entire area in the buccal plate. We know from the CT scan that we have approximately 5 to 6 millimeters of bone below the sinus wall. So we're going to attempt to incorporate simultaneous implant placement in conjunction with a osteotome sinus lift technique. And we're going to be utilizing a new technique, in this case, a piezoelectric device, to assist us in the lifting of the Snyderian membrane through the osteotome technique, through the osteotomy site. Lifting of the flap to gain access to the buccal plate. We can see that the original socket preservation has assisted us in redeveloping most of the intra-socket walls. This was done with mineralized irradiated bone. And approximately 3 months later, we can see we have some deficiency in the thickness of the ridge. We have some resorption, but entirely intact area for implant placement. What I like to do is to drill down to approximately 1 millimeter from the aspect of the floor of the sinus. I don't go beyond that. And once I get down to beyond that level, I then insert the piezoelectric tip. It's an end cutting tip. And you can see as I'm going down, I'm going up and down, trying to make contact with that cortical floor of the sinus. And once I feel that I go through, I stop completely. And one of the great things about that is it allows me to actually lift the Snyderian membrane or touch the Snyderian membrane without tearing it. And the piezoelectric device allows me to do that. We follow that with the osteotome, just with hand manipulation. And you can see on this close-up that the Snyderian membrane remains intact and there's been no tear. In this case, we're going to use fibrin, PRGF, Dr. Eduardo Anitwist protocol from BTI, and we're going to then push the fibrin up into the floor of the sinus utilizing an osteotome technique and hand manipulation. A mixture of mineralized bone in conjunction with PRGF, plasma-rich and growth factors, and slowly tapping this bone utilizing hydraulic pressure with the fibrin, with the PRGF, in multiple layers. You can see how this is being added one after the other to ensure that we get a good lifting of the Snyderian membrane without tearing it. We have the hydraulic pressure of the fibrin in combination with the PRGF gently lifting the sinus floor. And I'm using hand pressure and just very lightly tapping on this with the mallet. And then again, continuously adding the PRGF fluid into the osteotomy preparation. Once this is done, we then place a regular diameter implant into the prepared osteotomy site. And we can undersize these holes in type 2 and type 3 bone to get very, very good initial stability of the implant. Here we are placing the implant down to 40 to 45 Newton centimeters of initial insertion torque. I then go to the ratchet to completely seat the implant. So we now have lifted the sinus utilizing piezoelectric surgery in combination with the osteotome technique. And we utilized as well the PRGF and the fibrin from Dr. Eduardo Anitwist protocol as a bioactive modifier and also for the hydraulic pressure and carrier of the bone graft. Cover screw is going to be placed onto the implant. And what we like to attempt to do is not only worry about the apical end and placing in a normal length implant. In this case, a 10 millimeter implant was inserted in an area that only had 5 millimeters of bone. But we're also going to use a PRGF and a mixture of xenograft and mineralized irradiated bone to overbuild the bone on the buccal plate, ensuring that we have at least 2 millimeters of bone in front of the threads in front of the implant body on the labial aspect. This will maintain and stabilize the ridge contour, not only for aesthetics, but also for long-term maintenance of the crest of bone at the collar of the implant. One of the nice things about the fibrin membrane, it's autologous. It can be shaped to protect the underlying bone graft, and this retains itself in position before resorbing in approximately 3 to 4 weeks. At this moment, then, we can secure the flaps as we normally do. It's pretty routine with horizontal mattress sutures as the first suture to gain primary closure, tension-free. Once this is done, we then do interrupted vertical mattress sutures in the areas of the interdental papillas, and the PRGF fluid then placed over the incision lines just for added influence of this bioactive modifier. Preoperative image, and then at approximately 14 days, you can see primary closure maintained with a good thick ridge form, and you can see how the sinus has been lifted approximately 5 millimeters. We'll be coming back and seeing this case once it heals in approximately 3 to 4 months. And I hope it gave you some interest in the utilization of combined procedures, bioactive modifiers like PRGF and fibrin in combination with piezoelectric surgery and the osteotome technique to lift the sinus and to augment the ridge in the buccolingual direction. We thank you for being with us and look forward to seeing you again at Dental XP.